Hello, everybody. Good afternoon. And it's a very difficult topic to talk about clavicle transposition because it's a very rare indication and have some limitation. And at first, I want to thank Dr. Soldado. It's my friend and my brother Soldado, and thank Dr. Kozin about this invitation. So we'll talk about transposition of clavicle and some indication. We have nowadays a lot of patients with malignancy, especially in the proximal humerus, like those cases. There is many options to reconstruct this kind of tumors because it's a challenging pathology and a challenging invasion of surrounding soft tissue and so on. So we'll talk about some introduction. We'll talk about clavicle transposition, and we'll talk about what happened in the proximal humerus. The proximal humerus is one of the commonest site of primary and secondary malignancy, especially sarcoma, sarcoma, even sarcoma, and secondary like breast cancer, lung or renal cancer. Several techniques have been established to reconstruct, so like arthroplasty or free vascularized fibula, or maybe amputation in some cases. So the case is different to each other. One such reconstruction, like clavicle humerus. We'll talk about some techniques and tricks of this procedure. Before we will describe the pathology or the classification, this is the commonest classification of shoulder girdle, classification of tumors around the joint. We will here in this classification, we will choose the first one, because first type 1 attacks the proximal humerus, and the fourth attacks the proximal humerus and part from the scapula, and the fifth attack more of the humerus and part of the scapula. So the type 1, type 4, and type 5 we will talk about in this lecture. And there is some modalities for reconstruction. As I said, maybe leave the shoulder as a flail, unreconstructable, maybe put passive spacer or allograft or autograft. We will see maybe arthroplasty or arthrodesis. Making a choice between stability, you need a stability or a strength or both, or a mobility of the shoulder. So it's different technique to use. So it's very important point to look about what about soft tissue surrounding the tumors, how invaded by tumors. In deltoid preservation cases, you can use reverse shoulder arthroplasty. But in patient with deltoid and rotator cuff preservation, primary tumor arthroplasty is sufficient. But if you have deltoid and rotator with or without scapular resection, maybe use arthrodesis or clavicle are indicated in such case. So according to the patient selection, according to the patient itself, we can use or choose the sufficient treatment. Like those patients, this patient have arthrodesis, and another patient have arthroplasty, and another patient have clavicle humerus. So the commonest in use in past 30 years, Enneking method by using allograft arthrodesis in most stable reconstruction for young patient with vigorous activity. So that we use or we choose the stable joint, the arthrodesis, because it gives us more stable reconstruction, and it gives us some motion, costal or costo-scapular motion, and good motion for elbow and hand range of motion. So clavicle humerus reconstruction was previously performed primary in patient with upper extremity phocomelia, and described before. And the first man who described this technique is Winkelmann, in his big boss of tumor in EU. And this is the last, this photo was at the last meeting, tumor at Spain, last March. This is Winkelmann and his wife, me, and Dr. Sadiq, my mentor in Egypt. So is detectable medially and rotated downward, keeping its feeding vessel intact. So in this technique, we will describe how to rotate the clavicle to proximal humerus by attachment, by sparing attachment of acromioclavicular joint, because the main vessels of feeding vessel of that clavicle is acromioclavicular junction. The most important aspect of this method is that acromioclavicular joint is preserved to maintain continuation of the scapula and the clavicle. This feature contribute for post-operative shoulder stability after treatment with without arthrodesis. It indicated in limited cases after extensive resection of malignant tumor removal, skeletal architecture of the green humeral joint, in addition to removing the proximal humerus and scapula of the scapula, rotator cuff, all or part of deltoid muscle, and the axillary nerve. In bad situation of the vessels, you can use this clavicle transposition, and in limited donor graft, we have some cases with amputation, we have some cases of bad vessels or ischemic lower limb, we cannot use a free vascularized fibula. Like this patient, we use in this patient, this is osteosarcoma and a pathological fracture, and we will describe some different techniques. And after excision of the tumor, like that, this is a huge tumor. So this in this patient, it's a long excision of the humerus. So we cannot use a proclavicular for that patient. So you use the free vascularized fibula with arthrodesis. And in another patient like that, we can preserve rotator, we can preserve the deltoid muscle, we can use arthroplasty in that patient. So the advance of the clavicle to proximal humerus, it is the biological symbol after wide resection of malignant tumor with removal of the rotator cuff and all part or not of deltoid muscle. It provides a solid and stable moment. And when you see the configuration between the clavicle and the proximal humerus, is that same configuration between the same configurations, the same shape of the clavicle and the proximal humerus, and they give us some motion after surgery. But and also the clavicle have some advantages because we can augment the humeral length by adding vascularized fibular autograft. When you have a more or whole length of the humerus excised after a tumor, we can use both the clavicle and free vascularized fibula. So also in advantage of that clavicle to proximal humerus is a short operative time, the vascularized bone graft, and you can start chemotherapy and radiotherapy as soon as you can, but with some limitation or complication like infection is the most common because most of the patients are sarcoma and use chemotherapy, and most of the patients suffer from immunocompromised. And the second common complication is the non-union of distal, non-union between the humerus and the clavicle. The tricks of that transposition, you should preserve the costoclavicular junction, like 5 millimeters for ligaments and so on, and you can remove and dissect all superior, inferior of the superior, inferior soft tissue structure, trapezius, sternocleidomastoid muscle, and so on. And you must preserve acromioclavicular junction because the main supply, the main blood supply of the clavicle, like that photo, and do your medial osteotomy. And after that, you can move the clavicle to the proximal humerus, like that photo, and the same configuration. Also, you can do a configuration of the implant and close. This is the implant. You can configure the implant like the clavicle, and after that, you close the soft tissue surrounding the clavicle. We will. I will describe two cases. Is a female patient suffered from chondrosarcoma with aneurysm, secondary aneurysm bone cyst on top of chondrosarcoma, and that photo after embolization, just after embolization, and this is the histopathology and the plan for clavicle to proximal humerus because this patient were CP with flexion deformity of the knee, and we cannot use free vascularized fibula. And the dissection was done, and it was a big tumor, like 12 centimeters excision. And now after proclavicle transposition to the proximal humerus, and fixation was done with arthrodesis of the humeral to scapula, but with some motion to costoclavicular junction, scapulothoracic junction, and this is after 7 months. We see like that, but we have some of complication. We have injury or fracture of the clavicle itself, because one of the most complication is also is fracture at the angle of the clavicle, and because the clavicle is not straight bone, so we can see some complication like at the curvature of the clavicle. This patient have fracture at that site. And another patient, 20 years old male, presented by sarcoma, and this after 3 years. This is an old patient, and this after 3 years old, after clavicle to proximal humerus. He do some motion of the shoulder and elbow and head. Why not free vascularized fibula? Or what are the indication of the free vascularized fibula? Or when we should to do free vascularized fibula? The fibula requires skills in microsurgery, and they require learning curve, require good donor vessels, require team for harvesting and so on, with some donor side morbidity like fibular graft such as peroneal nerve injury to clawing, ankle instability, flexor longus weakness has been reported. In literature, there is some cases of clavicle to humerus. It's very rare cases, because some literature, 3 or 4 papers only describe this technique, and they will describe the conclusion of that article. They cannot directly compare this technique with other reconstruction option like arthroplasty or like free vascularized fibula, and the need longer follow-up is needed for that cases. But this may be useful in reconstruction in children and in patient with some limitation of donor site, like patient with CP, patient with amputated legs, and so on. And this paper compared between the arthroplasty and compare between the clavicle pro humerus or different technique for reconstruction of the proximal humerus. And the conclusion, there is a complication rate lesser than arthroplasty in that clavicle to proximal humerus, with MSTS score good more than or better more than arthroplasty. So at final end, there is a functional outcome is very nice or better than arthroplasty. After you finish your work, after hard work, you also always thinking and planning when you are drinking, when you are eating, you thinking about the patient. We see here my professor Kozin always thinking about what happened or what will happen in our cases. So in conclusion, the proximal humerus is a common site where bone tumor occur frequently, and limb salvage surgery is the preferred surgical option whenever possible. A clavicle pro-humerus reconstruction was comparable to other reconstructive technique, especially in children and short defects. CBH reconstruction is a type of local vascularized bone graft. The acromioclavicular joint is preserved to maintain stability and some motion. It's easy and simple procedure, not require learning curve, limited indication, especially in children with bad general outcome or prognosis, with long defect with composite fibular graft. And this is our photo in Cuba last meeting. It was amazing, and I learned a lot of things that. And now after we finished, we are happy because we are the winner because we did a success surgery with our professors. And this photo describes my mentor, Dr. Mahmoud, and my colleagues, Zogbi, Ibrahim, Mahmoud. This is our team in my hospital. And finally, I invite a few we will have all about peripheral nerve injury next November. We have 3 days of lectures, live surgery, and cadaveric course. Thank you so much for the invitation, and thank you so much. Bye-bye.
Amro, thank you so much. So a couple questions
Thank you.
Yeah, a couple questions have popped up.
Yeah.
So when you rotate the clavicle, what do you do with the coracoacromial ligaments? Do you have to section them? Do you have to take them down to get enough rotation?
Yes, of course, yes. Of course, yes. To get more length and to get all the clavicle.
Second question is, have you ever done it where your acromioclavicular joint detached, like just because you rotate it so much? I didn't realize it could move that much.
No, because acromioclavicular ligament is the main donor of blood supply of the two things for blood supply in the clavicle. You should preserve the all periosteum surrounding the clavicle, and the acromioclavicular ligament is mandatory to get a vascularized bone graft.
So does the blood supply come from that direction? Meaning it comes from it comes down the clavicle toward from lateral to medial, I guess is the question.
Yeah, from lateral to medial, yeah.
Okay. I mean, it's an amazing amount of rotation. And then the other question, I think what I would be worried about is especially the medial clavicle, because the subclavian is so close. Do you do anything in particular to protect the subclavian medial?
Yes, because we do a lot of brachial plexus, so it's for us it's not so difficult. But for recommendation of from especially posteriorly, and especially when you cut by we use a giggly saw, not a saw, because you can control through the giggly saw. You can butt the giggly saw from superior to inferior, and but when you use a saw, you can't control anything.
I'd have to go into the back and try and find a giggly saw from the old pelvic osteotomies. I don't know if we still have a giggly saw. Although I agree with you, it's an incredibly safe saw. I agree 100%. Paco, do you even have a giggly saw around anymore?
And sometimes.
Yeah. I'd have to find it. And then Amro, have you ever, and I think I may have missed this in the talk, if you rotate the clavicle down and then you still have a gap, is that where you'll put either your vascularized or non-vascularized bone graft? Is that what you'll do?
Yes. We measure our defects after before we have a planning before. If we need another distance, we use free vascularized fibula, or maybe if the patient haven't a good donor of free vascularized fibula, like in CP patient or paraplegic patient and so on, we can use iliac crest or maybe a second toe to get a lens, or maybe you can do acute shortening.
Right. I mean, I think that's the dilemma, right? If you have a defect and then you're trying to decide whether you're going to add bone graft, add a fibula, or just put a fibula across the whole thing, is there any way you make a decision? I mean, because if you're going to get the fibula, might as well just get the fibula, right?
Yeah.
We
use a fibula, yeah.
Okay. And then if you use a fibula, and again, I don't do much tumor work at all, actually. If you use a fibula instead of the clavicle, where is the proximal attachment? Where do you stick it? The fibula.
The fibula, I use a fibula and insert the fibula through glenoid after debridement of all cartilage and so on. I put it in the glenoid with a screw, and also another fixation through clavicle, spine of the clavicle to spine of the scapula to the humerus.
I see. To the fibula.
Yeah.
From above. From above, you mean? Okay. And then you bridge it with a plate anyway to neutralize it. Yeah. I mean, I think it looks like it's incredibly difficult surgery with the clavicle, without this clavicle. Paco, any comments, questions before we move on?
No, I just have one question. What is your ideal indication for this type of reconstruction in tumors?
It's very limited.
I mean, if there is deltoid, you prefer this. If not, you prefer a fibular arthrodesis, or?
No. The same indication of the clavicle is the same indication, or are the same indication of the prevascularized fibula. But we use a clavicle in short distance defect. Okay, you use a clavicle short distance, or if the patient haven't fibula, in patient patient paraplegic patient or a CP patient, I haven't fibula, prevascularized fibula. So I can use a clavicle in that limited indication.
Okay.
But with the clavicle, I understand that you will have some scapulohumeral motion, while with the fibula you will do an orthodesis. So if
Yes,
you have,
but
so if you have,
if you see,
yes. So if you have some deltoid, it's better to do a clavicle than a fibula, right? To get some motion.
No. If I the main indication of the fibula is the main indication of the clavicle. Okay.
Okay.
But in those patients, we haven't deltoid and rotators, because if I have a deltoid and a rotator, I can do arthroplasty.
Yeah.
Okay.
And
So,
for example, in a young patient, have you ever considered with deltoid? You have deltoid in a young patient. Have you ever considered the clavicle instead of a prosthesis?
yes, no problem. But if I have a deltoid and there's availability of arthroplasty, we can do arthroplasty. But in Egypt, we have a limitation also nowadays in arthroplasty, because nowadays, last year, it's so expensive because economical problems. So we use a prevascularized fibula every time for those patients, and get a good range of motion of scapulothoracic motion after arthrodesis. I have a patient with more than 60 abduction, flexion, and extension, and can do a lot of things after shoulder arthrodesis by fibula.
One last question, though, to just tag team what Paco said. If you take the clavicle, right, what does that do to your scapulothoracic motion? Is it good or bad? If you do your technique, I don't.
In some cases, we just fix the humerus and the clavicle only, and leave the shoulder through the acromioclavicular junction motion. It's the motion came from acromioclavicular, not from thoracoscapular. Okay, but then you have in another cases with shoulder arthrodesis, the motion came only from thoracodorsal or scapulodorsal
I see.
thoracic junction or joint.
I see. So all the motion occurs from the AC joint. I got it, because that's the only attachment. Right, because it's kind of separated from your scapulothoracic joint. It's a fascinating thing to think about, actually.
Yes.
Yep. And there's one more question. Do you ever use a pec major transfer for deltoid function? I guess.
Do you ever use?
No, you use the.
No.
Okay.
No.
Yeah. I think it's such a salvage situation. You're just lucky to get out of there alive, right? Literally. Yep. Paco, I'm going to move on. Is that okay?
Perfecto.
All right. I am going
Thank
to
you.
move. You're welcome. Thank you very much.